Okay, so I'm going to finish the chapter on neurodevelopmental disorders. The last neurodevelopmental disorder we're going to discuss are motor disorders. So let's discuss developmental coordination disorder. The primary form of motor disorder is developmental coordination disorder. Children with this surprisingly common disorder experience marked impairment in their abilities to coordinate the movements of their hands and feet. Affecting as many as 6% of children, developmental coordination disorder can lead to problems in academic achievement and ability to engage in ordinary tasks of daily life. There may be subtypes of developmental coordination disorder, with one subtype limiting hand-eye coordination and the other causing visual spatial difficulties. Children whose coordination disorder represents deficits in executive function, meaning they cannot gain control over their motor functions, represent another important subtype. In infancy and early childhood, children with developmental coordination disorder have trouble crawling, walking, and sitting. As they develop, their performance on other age-related tasks also is below average. They may be unable to tie their shoelaces, play ball, complete a puzzle, or even write legibly. Consequently, they may experience problems of low self-esteem. In addition, their lack of coordination may make them less able to participate in sports and exercise programs, leading them to become overweight. Given the complexity of their symptoms, children with motor disorder seem to benefit from an integrated approach that identifies the needs of clients and their families in the early stages, when symptoms first begin to emerge. An integrated approach to assessment can then proceed, in which children, families, and professionals share their perspectives on the child's symptoms and start to formulate therapeutic goals. Next, professionals, parents, and children plan how intervention will proceed, taking advantage of community resources. Here again, all must collaborate in setting goals for the child. They should base their planned interventions on evidence-supported treatments. Finally, the intervention team should develop strategies that will continue to support the children and their families as they transition to self-management within the home, school, and the community. Early identification of children with these disorders also appears to be key, with interventions before entrance to the school system regarded as particularly beneficial. Such interventions can also help prevent secondary consequences of the disorder, including poor self-esteem and increased risk of depression, anxiety, and obesity. Another motor disorder is tic disorder. A tic is a rapid, recurring, and involuntary movement or vocalization. There are several kinds of tic disorders. Examples of motor tics are eye blinking, facial twitches, and shoulder shrugging. Vocal tics include coughing, grunting, snorting, coprolalia, the uttering of obscenities, and tongue clicking. Tourette's disorder is perhaps the best known of the tic disorders, affecting approximately 1% of children, the majority of whom are male. People with this disorder experience a combination of chronic motor and vocal tics. Their disorder begins gradually, often with a single tic, such as eye blinking, which over time grows into more complex behaviors. The tics can include uncontrollable movements of the head and sometimes parts of the upper body. In some cases, individuals engage in complex bodily movements involving touching, squatting, twirling, or retracing steps. At the same time, they utter vocalizations that sound odd to others. For example, an individual may have a complex tic behavior in which he rolls his head around his neck while making sniffing and barking noises. In only a small percentage of cases do people with Tourette's disorder utter obscenities. This is not a passing condition, but one that can be lifelong, with onset in childhood or adolescence. Individuals with this disorder also have other psychological symptoms, the most common of which are obsessive-compulsive symptoms, speech difficulties, and attentional problems. Deficits in brain inhibitory mechanisms in the prefrontal cortex may be involved in Tourette's disorder, a feature that is shared with obsessive-compulsive disorder and ADHD. The condition may resolve itself by adulthood as the brain structures that inhibit the tics mature. Children with Tourette's can benefit from educational interventions that help bolster self-esteem and provide supportive counseling. However, if the tics are painful, self-injurious, such as scratching, and cause significant disability, clinicians need to intervene more systematically. Individuals with these symptoms can benefit from a form of cognitive behavioral therapy that uses habit reversal. In this approach, the professional trains clients to monitor their tics and the sensations that precede them, and then respond to them with a voluntary behavior that is physically incompatible with the tics. Cognitive behavioral treatment is the first line of treatment, but if this proves to be ineffective, clinicians may place the individual on pharmacological therapy, which can include SSRIs, atypical antipsychotic agents, and in extreme cases, deep brain stimulation. Stereotypic movement disorder. Children with stereotypic movement disorder engage in repetitive, seemingly driven, non-functional behaviors. These can include waving their hands, rocking their bodies, banging their heads, and biting and picking their skin. As you can imagine, these behaviors can interfere with their normal functioning and cause them to injure themselves. Ah, my nose. It is important to distinguish stereotypic movement disorder from the developmentally normal repetitive movements estimated to occur in as many as 60% of children between the ages of 2 and 5 years old. Subgroups of children are particularly likely to engage in stereotyped motor disorders, including children who are blind and those who have developmental delays. For children who are truly impaired or who risk serious injury as a result of their behavior modifications appears to be the most efficacious way to help them stop engaging in the behavior. Parents can be taught how to use behavior therapy in the home, an effective method particularly for children between the ages of 7 and 8 years old. Oh, never mind, there's one more neurodevelopmental disorder in this chapter. The biopsychosocial perspective. Oh, maybe that's not a disorder, it's just the perspective. Okay, so the disorders that you read about in this chapter include a range of conditions that reflect, to differing degrees, combinations of biological, psychological, and sociocultural influences. Genetic influences on many of these disorders are clearly evident, but even so, interactions with social context play an important role. Moreover, because these disorders begin early in life, they have the potential to exert profound psychological effects on an individual. Family factors also play a critical role, given the importance of early childhood experiences as contributors to psychological outcomes. Just as the disorders reflect multiple influences, so do treatments. In providing interventions to children, clinicians are becoming justifiably concerned about the use of medication. Treatment from the behavioral perspective seems to have a number of advantages because children's symptoms may be particularly receptive to treatments that focus on principles of reinforcement. The tremendous growth of interest within the past few decades in the conditions that can affect children means that considerably more information about causes and interventions is available than was true even a few years ago. Although interventions can be effective for people of any age, targeting children as soon as possible can help them achieve favorable outcomes that can influence their lives for decades to follow. Okay, let's go over the summary for the neurodevelopmental disorders chapter. Neurodevelopmental disorders include disorders that strike children early in life and appear to affect their behavioral functioning by creating brain abnormalities. Intellectual disability refers to intellectual and adaptive deficits that are first evident in childhood. Genetic abnormalities are a significant cause. The three most important genetic causes are Down syndrome, phenylketonuria, and Fragile X syndrome. Another genetic disorder is Tay-Sachs disease. Environmental hazards during prenatal development are the second category of causes of intellectual disability. These hazards, called teratogens, include drugs and toxic chemicals, maternal malnutrition, and infections in the mother during critical phases of fetal development. Consumption of alcohol during pregnancy can lead to fetal alcohol syndrome. People with intellectual disability can benefit from early intervention aimed at providing them with training in motor coordination, language use, and social skills. Educators can combine mainstreaming, which integrates them into ordinary school classrooms, with special education that provides them with assistance geared to their particular needs. The DSM-5 authors created the category of autism spectrum disorder to provide a more reliable and valid distinction between children who clearly show typical development and those who demonstrate the range of deficits in communication and social behavior that DSM-IVTR attempted to differentiate. The new spectrum format for this category underscores the commonalities between disorders previously considered discrete. Disorders listed separately in DSM-IVTR, such as Asperger's, autism, Rett syndrome, childhood disintegrative disorder, and pervasive developmental disorder, are included in autism spectrum disorder in the DSM-5. Symptoms that formerly differentiated these disorders from one another now are indicated by diagnostic specifiers. Evidence pointing to patterns of familial inheritance supports the theory that autism spectrum disorder is biologically caused. Although it's evident that neurological differences exist between people with and without this autism spectrum disorder, the basis for these differences and their implications are not clear. The behavioral perspective is the most relevant to treatment, particularly interventions that rest on principles of operant conditioning practiced by student therapists and parents. Disruptive and self-stimulatory behaviors will decrease if children with autism spectrum disorder receive reinforcement for appropriate behaviors, such as asking for help or feedback. In such instances, they are less likely to engage in self-injurious or aggressive behaviors. The specific learning disorders include impairment in mathematics, written expression, reading, and communication. Communication disorders include speech-sound disorder, childhood onset fluency disorder, and social communication disorder. For the majority of children with specific developmental disorders, schools are the primary intervention site. Attention deficit/hyperactivity disorder, ADHD, is characterized by inattentiveness or hyperactivity and impulsivity. There are many theories about the cause of this disorder, but familial heritability rates may be as high as 76%. Although researchers have found fundamental and structural abnormalities in the brains of people with ADHD, most agree that genetic vulnerability interacts with environmental exposure. Treatment takes a multi-pronged approach. Developmental coordination disorders are characterized by tics, recurring involuntary movements or vocalizations. This type of disorder includes Tourette's and stereotypic movement disorder. The disorders covered in this chapter include a range of conditions that reflect, to differing degrees, combinations of biological, psychological, and sociocultural influences. Genetic influences on the development of many of these disorders are clearly evident, but even so, interactions with social contexts play an important role. Moreover, because these disorders begin early in life, they have the potential to exert profound psychological effects on an individual. Okay, that was neurodevelopmental disorders. I have a psychology channel. It's called ADHD TDAH Canal because it's bilingual in English and Spanish. So if you guys want to check it out, go follow me. Once I get 50 subscribers, I can go on live there. And okay, I'm gonna watch my lesson now. I read the book first, next watching the lesson, next doing the study guide. Thank you for joining me. Bye.